RPA PAL is sponsored by an educational grant from Amgen, and we appreciate their support. Finally, be sure to check the RPA website for upcoming webinars and events. I will now turn this over to our moderator, Dr. Fold. Thank you.
Thank you, Amy. I want to introduce Rob Blazer, who most people, I believe, are familiar with, but he's been the Director of Public Policy since 2003. He was previously with RPA since September of 1997. He has been taking the lead in drafting over 30 position papers for RPA. And Rob is a Program Director of the Political Action Committee. He was actively involved in the Capitol Hill Day yesterday and encouraged people to continue to participate in that. He's also well known for his public policies in the Minute. He's also a fellow Terps fan, which is a big plus. In any event, let me turn it over to Rob so he can go over the interesting policies and things going on in Washington. Thank you.
Thank you, Bob. I appreciate it, and go Terps. Let me make sure the slides are advancing here. Steve, they're not advancing for me here. Here we go. Those of you who've seen me give this talk before know I break it down by a legislative overview and a regulatory overview, and I'd like to start the legislative overview with where we were a year ago. Gives us some context for the rest of the stuff we're going to talk about later in the day. Always good to talk about the state of play in DC. It's an interesting place. And then I'm going to discuss RPA's legislative agenda for 2020. Next slide. Okay, for the regulatory overview, we're going to talk about the Advancing American Kidney Health Initiative. Now, I know Drs. Gillian and Ketchertsid spoke about that at length this morning, so I might go over a couple of the what's in it slides pretty quickly and then just talk about RPA's input on those various initiatives and then where we think things might go in the future. Of course, telehealth has been a big deal in Medicare, so we're going to have a few slides on that. Talk about the Medicare fee schedule for both 2020, what they did last November, and what we think is going to happen in 2021. The rule should be out within the next 10 days or so, the 2021 rule, and then vascular access reimbursement. Next slide. So where were we a year ago? We have this, there was an unorthodox presidency and administration keeping on, doing what they do, deregulation, privatization, that sort of thing. And the emphasis on legislating in 2019 was particularly acute given the looming election year, which if this were Twitter, I would have another line that says, narrator says they didn't do any legislating in 2019, really not anything apart what they really had to do. So Alex Azar was flexing his muscles at HHS, but interestingly, if you read the Washington trade press in terms of health policy, it seemed like he had a bit of a rivalry going with Seema Verma, the head of CMS at the time, and this was all over the news at that moment. The battle over the E&M code future, the evaluation and management codes, was in full fury. The values for these were increased about a year and a half in advance for this proposal that came through the RUC. But there is concern among this surgical and procedural specialties that's going to affect the conversion factor, so it's become a little bit of a food fight. And then the kidney payment initiative was announced 50 weeks ago. So next slide. So what is the state of play in DC? You know, suffice it to say, divided government does not facilitate consistent legislative success, and impeaching a president doesn't help. You know, the word is that Nancy Pelosi and President Trump haven't spoken since last November or last December. That certainly isn't constructive. And in the Captain Obvious department, the Congressional coronavirus response has completely upended everything going on in the Hill and the priorities. And that was, you know, evidenced by the fact that we had a virtual Hill Day last year. Nobody's visiting offices anymore, and all the congressional staff who we spoke to were sitting in their homes. So different times, of course. The COVID relief packages have been a bit of a double-edged sword. A lot of good things happening in there, but for now they're the only game in town, at least until the lame duck. And it's also interesting that they're spending so much money in these proposals that things that would have gotten argued about in the past just kind of get waved through. The example I'm thinking is the Medicare extenders bill that everyone is hoping immunosuppressive drug coverage would be attached to in May, and it ends up that they just folded it right into, I think, the first COVID bill, because, you know, what's 40 billion when you're spending $1 trillion, you know? So anyway, there's an interesting dynamic going on for Democrats right now. The Biden candidacy ends up meaning that vulnerable down ballot Democrats are potentially less likely to hand President Trump a legislative victory. If one of the more progressive candidates had come out of the Democratic presidential nomination process, they might have been more likely to do less centrist things, or excuse me, I should say more centrist things, but now they don't necessarily have to because they sort of got coverage at the top of the ticket. And then the increased focus on the kidney health initiative that has raised the profile of all kidney issues, but in the, you know, there's plenty of slip between the cup and the lip department. Whether this results in enacted legislation remains to be seen. Next slide, please. So on the regulatory side, the administration COVID response in terms of Medicare policy and telehealth has really been nothing but historic. And I want to just take a moment about this. You know, I've been looking at monitoring regulatory events at CMS since 1995. My 25th anniversary of doing this is just this week. And it's truly remarkable, the swiftness with which they move, especially on the telehealth stuff. Literally within about 6 weeks, virtually everything was implemented that we're seeing now. And that would have taken a decade or more before. So of course their hand was forced and they had to do it, but you really got to give CMS a lot of credit, Seema Verma a lot of credit for making that happen, because it really turned on a dime. So, and that kind of leads into the next bullet. The leadership ups and downs at HHS and CMS have been pretty fascinating. Alex Azar is the gold standard in a Trump cabinet. You know, he was a deputy secretary in the Bush administration of HHS, so he knows how everything's supposed to work. And so he's as good a cabinet head as any in the whole administration. But you know, during the pandemic, he was on the receiving end of some tough tweets from the president about why aren't things working better. Seema Verma had a more rocky rollout during her early days in the administration, but she's gotten exceptionally high marks for what's happened with COVID and the implementation of telehealth. So kind of remarkable how that's all worked out. So huge changes in kidney care reimbursement, organ procurement, and financial support for organ donors have been proposed, revised, and delayed. And more of this, I would venture to say, is likely to come, but you know, we'll have to see what happens. And then, as I noted before, the E&M code changes are looming for 2021. Whether they remain unrevised or not, we'll see that in the fee schedule in a couple of weeks. Next slide, please. So just a word about the Congressional Kidney Caucus. It's been reinvigorated in the last year or so. There's a cardiothoracic surgeon from Indiana who has joined as the Republican co-chair. Larry Bouchon from, I believe he's the Indianapolis suburbs, has joined Susan Del Bene from the Seattle suburbs as co-chairs. And the purpose of the Congressional Kidney Caucus is to promote advancement of legislation that improves kidney disease care and educational efforts both in Congress and more broadly. And they've done some stuff. They actually weighed in on the ESRD treatment choices model with some concerns. Essentially what they said was listen to the community and don't go too fast. Make sure you don't try and put something out there that's not implementable. So next slide, please. Moving into RPA's 2020 legislative priorities, really the big kahuna for this year is the Immunosuppressive Drug Coverage Bill. You can see the bill numbers there. The House bill came out right before Christmas, and the Senate bill came out right before pretty much everything shut down for COVID. Lifetime coverage, that is coverage for the life of the transplant, is the goal. And we really have an unprecedented opportunity right now. This administration, in keeping with everything else they've done in kidney disease, is all in on this. The Department of Health and Human Services Assistant Secretary for Planning and Evaluation and the Office of the Actuary both had separate reports indicating that it would be a saver. And the OAC number was $300 million over 10 years. And this, of course, is a good thing. there was a period of time when as soon as something was a saver, you knew eventually it was going to become law because Congress wants to spend that money. Slightly different terrain now with all the money they're spending on COVID, but it's still meaningful. And I would venture to say that it's got great bipartisan support in both chambers. Leadership is all behind this. If there's any kind of reasonable Medicare package, probably in the lame duck, the chances are I think this will be included, but we're going to have to push hard for that. We even heard some rumors yesterday during our Hill visits that this could be included in the July COVID package, assuming that happens. And for the first time yesterday, we heard that the COVID package might have a difficult time getting done before the August recess, which it just blows me away, but I guess it is what it is. Anyway, next slide, please. We also lobbied on the Living Organ Donation Bill, the Living Donor Protection Act, and you can see the bill numbers there. It was introduced in February of 2019, so we're going on 18, 19 months since it got introduced. It addresses the barriers to organ donation by prohibiting denial of coverage or increased insurance premiums for living organ donors, designates organ donation surgery as a serious health conditions for the purposes of the Family Medical Leave Act, and requires HHS to update educational materials. It is important to note that I believe it was August of 2018 that the Department of Labor essentially said, we are considering it a serious health condition for the purposes of the Family Medical Leave Act. And that was a great win, but we want to get this put into law so we don't have to worry about another administration further down the road kind of reconsidering this. So currently 80 co-sponsors in the House, 18 in the Senate. I don't think this has quite as good a chance as the Immuno bill of becoming law this year, but it's definitely in the mix. And again, I would think there's going to be some sort of Medicare package in the lame duck session, and that would be when this would happen. Next slide, please. So the community CKD bill, it's called the Chronic Kidney Disease Improvement and Research and Treatment Act, S1676, HR 3912. This is a bill that comes out of kind of the community process. Kidney Care Partners is sort of an umbrella group for a lot of groups in kidney care, and RPA belongs to Kidney Care Partners. And they always come out with a bill every Congress with sort of an omnibus set of things the community would like to see get done. And the things that we care a lot about are the fact that it increases access to the kidney disease education benefit, a GAO study on the use of palliative care in treating patients with kidney disease, promotes kidney care in underserved areas by loan forgiveness, adding nephrology health professionals to the National Health Service Corps, and guarantees access to Medigap policies to all beneficiaries regardless of age. I would also say there's provisions in there that would promote innovation in kidney disease care where it's been sorely lacking over the last couple of decades. There are a couple provisions in there with regard to payment methodologies in the ESRD prospective payment system, which is the way dialysis facilities get paid. This bill is not the type of thing that's going to get passed as a bill. It sort of serves as a platform for provisions to be plucked out of and put into other bills, and it's been successful with that. Acute kidney injury provisions, home dialysis payment provisions, ESRD and Medicare Advantage provisions. Those are the type of things that have happened over the last couple of years, and they were all part of this bill at that time. So next slide, please. So oversight of the CMS nephrology quality measurement process. And this first bullet is kind of a qualifier here. We as RPA are completely committed to quality measurement in nephrology, and this is evidenced by the fact that we're the only group that came up with a qualified clinical data registry in the space. So, that's a lot of work and a lot of financial investment, and we did it. So there's no doubt that we're into this. However, RPA objects to the CMS's unilateral decisions to eliminate nephrology-specific measures, to increase reporting burdens with no clear benefit to patient care, finalize an AAKHI measure despite widespread opposition, and diminish the significance of QCDRs. So we're urging Congress to exercise oversight authority and make sure that CMS does what they're supposed to do. I can't tell you how many meetings I've been in with CMS staffers who've said, we just want to work with the community. But of course, there's not much evidence of that because when the community says do this, they don't. So next slide, please. So a quick slide about the RPA Political Action Committee. We're the only group with a PAC, so this is the only group, and you'll see that's all caps, so I'm yelling this right now. This is the only PAC that can specifically voice your concerns. We're neither Republican or Democrat. We support legislators supportive of the priorities of organized medicine and nephrology. We focus on the Medicare committees of jurisdictions, physicians in Congress, and leadership. There's nothing like those face-to-face interactions to get your message across with Congress. And you can see where you can donate now. Please do. The fact that the annual meeting got canceled this year was not good for the PAC. We normally get something like 75% of our donations for the year from the annual meeting. So we're at a deficit right now. Please contribute. Next slide, please. So the Advancing American Kidney Health Initiative. I'm not going to dwell on this too much because I know a lot of people already saw a presentation on this today. But very quickly, I'll look at the middle bullet there. 80% of new ESRD patients in 2025 will either start at home or a transplant. And I will tell you, the biggest proponents of the payment models think this number is way too high. Should be more like 50 or 60 or something like that. So that's one of the things that began to kind of maybe erode a little bit of the confidence in this model. Next slide, please. And I'm not going to dwell on this because you saw a presentation about this morning, although it's in the slide deck and people can review this later. But it's all the provisions of the ESRD treatment choices model. And again, you heard about this morning. Next slide, please. So this is what RPA said about it. The start date and the scope of the ETC model were too soon and too big. 50% of the country is a whole lot of providers to compel to be in this model, and they might not be able to do it. As noted, the benchmark was probably too high. There might be some potentially unintended negative impact on patient choice. There might be patients who don't want to do home dialysis who might be compelled to do it because of the incentives that were in the program. Have to have new waivers to make this happen. Worried about additional exclusions we needed additional exclusions for home dialysis and transplants. They generally put everybody into the denominator, which would be hard to make. The use of organ transplant rates and the exclusion of non-Medicare beneficiaries from transplant attribution was hard. Next slide, please. And this is about the voluntary models. I'm not going to go through this too much. The highlights here, I will say, is that in the CKD payment quarterly, we felt the number was kind of low, and that the fact that there was no separate E&M billing would be very problematic. But we'll have to say that the transplant bonus, as Drs. Ketterson and Gillian said this morning, the transplant bonus was pretty amazing that they included that. That's a big number. And that really did come out of the RPA PTAC proposal. And I've heard from people at CMS that's where they got the idea. So you deserve some credit for that. Next slide, please. So in terms of the input we gave on this, we worried about the minimum patient requirements. That would exclude practices. ACO overlap would preclude practices. The requirement for patients to be seen 2 times every 6 months was exclusionary. I talked already about the de facto 25%. I didn't talk about this. De facto 25% pay cut. You know, for ESRD patients, you'll get the mid-level payment. So if you've been doing 4 visits on your ESRD patients all along, you're getting a pay cut. The CKD quarterly payment was too small. The E&M services not being billable is unreasonable. And the use of depression remission and patient activation measures, probably inappropriate for use in a nephrology practice. Definitely depression remission. Next slide, please. So the comprehensive kidney care contracting models are pretty much the same as the kidney care first models, but you have the different levels of graduated risk. Next slide, please. So there were rules on organ procurement organizations, the conditions for coverage. There were living organ donation had rules as well. Next slide, please. Living organ donation was about reimbursable expenses to donors. So in terms of all of the rules, the ETC rule has been at O1B since March 10th. An opinion is split about the forecast. Will it come out as soon as the public health emergency is over? Will it be on the shelf much longer? Is there a small chance that it'll never get released? I don't think that's impossible. As noted before, the KCC models were delayed a quarter to Q2 2021, and that should say 1/1/2022 start date as an option for approved applicants. They extended the ESCOs a quarter, and we sent a letter to CMMI in April of this year. And I was told by CMMI people that our letter was very influential. And then the other rules haven't even made it to OMB yet, so we'll see what happens with that. Next slide, please. So telehealth and medicine, sweeping changes from the spring are still in place, but for how long? The public health emergency could end as soon as late July, but we're pretty sure that a lot of the telehealth stuff is going to continue. Seema Verma and presidential advisor Kellyanne Conway have made statements that there's a lot of support, so you would think if it's coming from that high, it's going to happen. Much support from the Hill, but it's not universal. House Democrats are wondering about it. Organized medicine is calling for a long extension. I think there's going to be a bunch of stuff that gets continued after the public health emergency, and things that we brought up that have not been changed is telehealth billing for acute kidney injury home dialysis and home dialysis training, and I don't think that's going to happen. And you can see where the RPA telehealth guidance is. Next slide, please. Medicare fee schedule, the final rule was released in November. This year's final rule last November. The conversion factor went up a nickel. Good changes coming to E&M, and they did a solicitation on the MCP based on the fact that the E&M component codes of the MCP are getting increased, and that's a good thing. We'll have to see if it ever happens, but the fact they asked about it is good. Billing for TCM codes is now allowed. This says place of service 65 allowed by some MACs. Pay attention to that. If you can't get it paid at place of service 65, use place of service 11. We put out news a couple weeks ago that CMS told us that that would be how that works. CMS created the principal care management codes. And again, we're expecting the new rule in a couple of weeks. Final E&M changes and possible vascular access revisions and the telehealth stuff should all be in this rule. Next slide, please. In terms of vascular access, there's been pretty good news recently. The concerns we've had over the last couple of years seem to be resolved for now. So the existential concerns, will I be able to do vascular access care, seems to not be happening. The CMS created new carrier price G codes for peripheral vascular access, but the LCD that came out was kind of flawed, and we're expecting the release of the proposed rules imminently. Amy's making faces at me on the screen right now, so I know I have to rush. Next slide, please. We had all kinds of policy victories last year. I won't run through these, but we had a pretty good year, excuse me, policy advocacy-wise. Next slide, please. So to wrap things up, the legislative stir-fry is on full display in DC right now. The fact that they got those first 3 COVID relief packages done as quickly as they did was impressive. No matter where you fall in the political scale, it's been harder to get number 4 done yet. The other mega issues like social unrest, November elections, and the sprint to telehealth permanence have kind of sucked a lot of the air out of the room in Washington. And the post-election November lame duck is going to be wild for a bunch of reasons. There's going to be a bunch of stuff they want to be done, and we want to see what goes on with the elections. If things were to go in the direction politically they look like now, it could be that the Republicans are going to be scrambling to get stuff done before they're not in power anymore. And the Medicare extenders package is going to expire in November, so we're going to do everything to get immunosuppressive drug coverage in there. Next slide, please. And this is my last slide. As noted, it was really impressive that CMS and HHS got telehealth done as quickly as they did. The current $64,000 question is what are they going to do next? And then the E&M code proposals, provider relief fund issues, and patients over paperwork are everything that people are lobbying on now. And in kidney disease, the administration decision on the ETC model is the largest outstanding question in kidney disease, and the proposed rules out there are all going to be released probably in the next couple weeks. And we are going to be on top of it for you. Amy, how did I do?
Great, Rob. Thank you. Why don't we go to the next screen so everyone can see your contact info?
Oh, there you go. Sorry.
So we are at time. Thank you, everyone, for joining this session. Please don't hesitate to reach out to Rob with any follow-up questions. There's all of his contact info. We also added in the link to donate to the PAC, should anybody wish to do so. If you were inspired by Rob's talk. So please go ahead and do so. And now you can close this Zoom window and either go back to the conference website or your email to launch the next session, which starts in about 10 minutes. Thanks so much. Bye-bye.